NAD gets fueled by the things that we eat. And then it becomes fully charged. The green circle over there where NAD is charged, it has an H on it, a proton. Then it goes into the mitochondria, and it does a lot of things in the mitochondria, but basically it donates the proton so that your cell can make energy, ATP, okay? And when it donates the proton, then it becomes NAD+, and it's looking for the next meal so that it can get charged again, okay? Does that make sense? Here's another diagram that shows so many different pathways. You have the Krebs cycle, you have glycolysis, all of these things that we learned in biochemistry, but basically it's showing how glucose is metabolized and how ATP and reactive oxidative species are made in the mitochondria. Anyone want me to break this whole thing down, or should we keep on going?
Keep going.
Yeah. And this is another slide to show there are 3 different pathways. You have the salvage pathway, you have the de novo pathway, and the Price-Handler pathway. But basically showing that all of them are heavily reliant on NAD. So NAD drives ATP synthesis through oxidative phosphorylation. It acts as a cofactor for sirtuins and PARPs, which are very important for DNA repair and regulating aging and reducing inflammation. It enhances cellular resilience and mitochondrial function. So some of the clinical uses patients do report after either subcutaneous injection or an infusion of NAD. They say that yes, they do have an increase in energy, sharper focus, faster recovery. Clinical research supports roles in metabolic restoration and neuroprotection and is used for anti-aging, integrative, and wellness protocols. So again, this is where you are going to figure out how does this fit into the patients that I'm seeing and the protocols that I'm building to treat these patients. So via IV infusion, anywhere from 100 to 750 milligrams in normal saline, not dextrose, not lactated ringer, nothing else, just normal saline. IM or subcutaneous injection, anywhere from 50 to 200 milligrams per week. I know in Monica's patients, they're about 200 milligrams per month. I think, yeah, most of your patients are 50 milligrams once a week. Yeah, and they come back. They come back for those refills. So the oral capsules, or any type of oral powder, you typically won't find NAD, raw NAD, in oral formulation. The reason is because it's not bioavailable, and it's not resistant to the gastric acids. Okay, so you'll typically see NAD over the counter or online in NR or NMN formulations. Okay, this NR converts to NMN. Okay, and then this one is what converts to NAD. Okay. Questions about NAD?